or if not, we're still going to do it.
They'll watch it online.
So to continue our respiratory physiology series, we're up to number 5, where we will talk about blood gas transport. So far we've talked about ventilation, and that had a lot to do with dead space and so forth. And then we talked about diffusion across the alveolar capillary membrane. Then we talked about blood flow through the lungs. Then we talked about gas exchange and VQ relationships and so forth. And now today we're going to talk about blood gas transport and acid-base balance, which has to do with things like the oxyhemoglobin dissociation curve and Haldane effect and the Bohr effect and so forth. Our objectives this morning are to describe the role of hemoglobin in oxygen and carbon dioxide transport, to describe the oxyhemoglobin dissociation curve, to compare the Bohr and Haldane effects, to list the causes of hypoxia, and then to list common causes of acid-base disorders. So let's then talk about oxygen transport and oxygen content and how much oxygen is loaded into the arterial blood. Oxygen is carried in the bloodstream in 2 forms, as dissolved oxygen, which is relatively little, as we will see, and as oxygen bound to hemoglobin, which has to do with the oxyhemoglobin dissociation curve. The amount of oxygen that dissolves in the bloodstream is determined by Henry's law, which says that the amount of oxygen dissolved, which the amount actually of any gas dissolved, oxygen or carbon dioxide, is determined by its solubility coefficient, its pressure, PO2, and temperature. At normal body temperature, the solubility coefficient for oxygen is 0.003 milliliters of oxygen per 100 milliliters of blood. So in other words, for a PO2 of 100, only 0.3 of a milliliter of oxygen is dissolved in 100 milliliters of blood. Not nearly sufficient to meet the metabolic demands of the tissues. So the point being, if we did not have hemoglobin, we could not survive. So hemoglobin is necessary for oxygen transport. Solubility varies inversely with temperature. So at a higher temperature, gas comes out of solution and exerts a higher pressure. Why is that important clinically? Well, why that is important clinically is that blood gas analyzers measure the PO2 and the PCO2 at 37 degrees centigrade. So if the patient's temperature is other than 37 degrees centigrade, what the blood gas analyzer measures will be different than what the PO2 is in the patient. So if the patient has if the patient is febrile with a higher temperature than 37, the PO2 will be a little bit lower in the patient than in the blood gas analyzer. On the other hand, if or be a little bit higher, I should say, because a higher temperature gas comes out of solution. So the way I think about that for Vinny is that if your beer is warm, the CO2 fizzes out of the solution a lot more than if it's cold. So if the patient's temperature is greater than 37, at the higher temperature, more gas will come out of the solution and the PO2 in the patient will be greater than in the blood gas analyzer. On the other hand, if the patient is hypothermic, then there will be more gas that will go into solution, so the PO2 in the patient would be less than what is measured in the blood gas analyzer. Now, there are algorithms that are actually built into the blood gas analyzer so that it's possible to correct or to adjust the blood gas to the patient's actual temperature. And that is controversial, actually, as to whether one should use that or not. Here, I believe this was certainly the case a couple of years ago when I was here all the time. If the patient's temperature was written on the blood gas slip, then the lab would make the temperature adjustment and report the blood gases at the patient's body temperature rather than at 37. But it's actually controversial as to whether that should happen or not. So as we just said, that very little oxygen dissolves in the bloodstream. So we need hemoglobin to transport oxygen and also to transport carbon dioxide, as we'll see in a minute. And the loading of oxygen onto the hemoglobin molecule is determined by the oxyhemoglobin dissociation curve, with oxygen saturation of hemoglobin as a function of the PO2. And as you know, that relationship is not linear. That is a sigmoidal S-shaped relationship, which has important physiologic meaning. For example, at a high PO2, oxygen binds easily to the hemoglobin. So, for example, the PO2 can drop from 100 in the lungs to 60 in the lungs, and the saturation drops very little. So in other words, at a PO2 of 60, oxygen is loaded onto the hemoglobin nearly as well as it is at a PO2 of 100 or 150 or 250. So because of the shape of the oxyhemoglobin dissociation curve, oxygen loads onto hemoglobin easily, quickly within the lungs. On the other hand, at lower PO2s, in the tissues, oxygen binds loosely to hemoglobin. So, for example, a normal tissue, PO2 is about 40 millimeters of mercury, which is a saturation of about 75%. If the PO2 in the tissues drops from 40 to 30, the saturation drops a lot. So at the tissues, the PO2, for a small drop in PO2, there's a big drop in oxygen saturation. So what that means is this is a lot of oxygen that is released to the tissues for a small drop in PO2. So in other words, if the tissues require more oxygen, the PO2 of the tissues will drop a little bit, and the hemoglobin will release a lot more oxygen to the tissues. Physiologically, exactly what you would want to have happen. So if you were to build hemoglobin for people like us, you would build the oxyhemoglobin dissociation curve in a sigmoidal manner to facilitate oxygen loading in the lungs, so you can get sick, you can get lung disease and drop your PO2 a lot, but still have a reasonable arterial oxygen saturation. And you would have a steep part of the oxyhemoglobin dissociation curve, so that if you become a little bit more hypoxic, the hemoglobin will readily release a lot of oxygen to the tissues. Now, increasingly, the way that we look at this relationship, so traditionally, the way we've looked at this relationship is we draw blood gas, we measure the PO2, and we calculate the saturation from the PO2. But now, because of pulse oximetry, we more commonly look at the oxygen saturation measured by pulse oximetry, and then we try to make some estimates about the PO2. And this table actually shows what the PO2 would be at oxygen saturations from 95 to 80%. And the point that to be made here is that, again, this is not a linear relationship. So we cannot extrapolate in our minds very well the PO2 from the saturation because of this non-linear relationship. But if you hang on to this table, then if your patient has a saturation of 92%, that should be a PO2 of about 64, provided that the oxyhemoglobin dissociation curve is normal. It's not left shifted or right shifted and so forth, as we'll talk about in a minute. And as far as characterizing the severity of lung function, we often look, particularly in patients with ARDS, at their PO2 to FiO2 ratio, and tables like this one were published just within the last couple of years, allowing one to look at the oxygen saturation off of the pulse oximeter and determine what the PF ratio is, knowing the FiO2. So, for example, if your patient is on 60% oxygen and their pulse oximeter saturation is 92%, that would be a PO2 to FiO2 ratio of 106, meaning the patient has moderately severe ARDS. Or if the patient is on 40% oxygen and has a saturation of 95%, their PF ratio is about 190, which is moderate ARDS. And I think for me, this is helpful to think about with a table like this, because how many of us would recognize that our patient on 40% oxygen with a saturation of 95% has a PF ratio which is less than 200, which means that they have moderate ARDS. So I think we probably don't appreciate that as well as we should. Well, unfortunately, unless you're a lot smarter than me, you can't memorize these kinds of relationships. And the reason why, well, you could, but it'd be very difficult because of the non-linear relationship between PO2 and saturation. And to complicate that more, the position of the oxyhemoglobin dissociation curve is determined by its physiologic environment. So there are things that shift the oxyhemoglobin dissociation curve to the left, such as these things, and there are things that shift the oxyhemoglobin dissociation curve to the right, such as these things. So then, what is the physiologic and clinical significance of shifts of the oxyhemoglobin dissociation curve? Well, if the oxyhemoglobin dissociation curve shifts to the left, such as hypothermia, or such as alkalosis, or such as a decrease in PCO2. A left shift of the oxyhemoglobin dissociation curve means that the hemoglobin has a higher affinity for oxygen. So in other words, if we shift the curve to the left, for any given PO2, there will be a higher oxygen saturation. So for a left-shifted oxyhemoglobin dissociation curve, for a given PO2, there will be a higher saturation. The problem with that is that the left shift of the oxyhemoglobin dissociation curve and the higher affinity of hemoglobin for oxygen means that the hemoglobin holds on to the oxygen more tightly and does not release it to the tissues. So you would first think, well, the higher saturation, wouldn't that be good? Well, maybe not good, because if the hemoglobin is loaded more tightly on, or if the oxygen is loaded more tightly onto the hemoglobin, then the oxygen is less likely to be released to the tissues. And that's a form of hypoxia, as we'll get to in a few minutes. On the other hand, a right-shifted oxyhemoglobin dissociation curve means that for a given PO2, the oxygen saturation will be less. So that means with a right-shifted oxyhemoglobin dissociation curve, like hyperthermia, acidosis, and so forth, the hemoglobin has less affinity for oxygen. So with a right-shifted curve, the hemoglobin gives up its oxygen more readily. And that has physiologic importance. Again, if you were to build human hemoglobin, this is the way you would want it to work. So this illustrates the Bohr effect, which is the relationship between pH and the position of the oxyhemoglobin dissociation curve. So the Bohr effect says that with acidosis, the curve shifts to the right, less affinity for oxygen. With alkalosis, the curve shifts to the left, greater affinity for oxygen. So how is that important? Well, how that is important is that in the lungs, the CO2 is removed from the blood. The pH goes up. So as the blood goes from the right side of the heart to the left side of the heart, the pH goes up. As the pH goes up, that shifts the curve to the left. When the curve shifts to the left, hemoglobin has more affinity for oxygen. So that means that in the lungs, the Bohr effect results in more oxygen binding on the hemoglobin. That's what we want to have happen in the lungs. We want, as the blood goes through the lungs, for it to pick up oxygen. On the other hand, in the tissues, as the blood goes through the capillary from the arterial to the venous blood, it picks up carbon dioxide. That lowers the pH, shifts the curve to the right. Shifting the curve to the right decreases the affinity of hemoglobin for oxygen. The lower affinity of hemoglobin for oxygen results in the hemoglobin releasing oxygen to the tissues. So in other words, then, as the blood goes through the lungs, it becomes more alkaline, curve shifts to the left, hemoglobin picks up oxygen. Exactly what you'd want to have happen in the lungs. As the blood moves past the tissues, from the arterial bloodstream to the venous bloodstream, the pH goes down because carbon dioxide is coming out of the tissues. That shifts the curve to the right, causes hemoglobin to release more oxygen to the tissues. Exactly the way we would probably want to engineer the hemoglobin to work. So we've only had to have, what, 1 billion years of evolution to get all that worked out. And as you know, from some people, we won't get into it today, in some people, that still hasn't worked out very well because they have hemoglobinopathies, sickle cell disease, and so forth, which interfere with these kinds of things. So I put this slide in as a point of caution when extrapolating the PO2 from the oxygen saturation. And this relates to the effect of acidosis and other things on the position of the oxyhemoglobin dissociation curve. So imagine that your patient has a pH of 7.4, normal pH, and their oxygen saturation is 90, and that corresponds to a PO2 of 60. And that's one of the points that most of us remember from the oxyhemoglobin dissociation curve. PO2 of 60 is a saturation of 90. But now let's imagine that our patient becomes acidotic. So the pH drops from 7.4 to 7.25. So maybe the patient has an increase in PCO2 or develops some lactic acidosis. Whatever is the cause, the patient develops some acidosis, which shifts the oxyhemoglobin dissociation curve to the right. It goes from here to here. Notice that that results in the saturation dropping from 90% to 85% without any change in the PO2. So we need to then be careful about how we extrapolate the PO2 from the oxygen saturation, because in this example, the patient desaturates due to a change in pH, due to the Bohr effect, not because there was a change in the patient's lung function. So that would lead some people to say, well, maybe we need more information than just the pulse oximeter saturation, and maybe there are good reasons why we should still be drawing blood gases rather than over-reliance on the pulse oximeter. One of my other talks that you might have seen the other week when I was here, one of my lines is, beware of the seduction of the pulse oximeter. Because we get, remember that line? So because we get so sucked into, looking, at the pulse oximeter that we forget about some of these other things. So just because your patient desaturates does not necessarily mean that the patient's PO2 has gone down. So oxygen content then puts together PO2 and oxygen saturation. So the content, oxygen content, is determined by how much oxygen binds onto the hemoglobin, which is 1.34 milliliters of oxygen per gram of hemoglobin, times the hemoglobin concentration times the oxygen saturation, plus the solubility coefficient times the PO2. So for example, if you have a hemoglobin of 15 and an oxygen saturation of 97% and a PO2 of 100, your oxygen content is about 20 mLs per 100 milliliters of blood. So textbooks will list the normal oxygen content as 20, and that's the math to show that. What also this slide illustrates is that the oxygen content is determined almost entirely by the amount of hemoglobin. So the amount of dissolved oxygen, the dashed line, adds very little to the oxygen content because the solubility coefficient is such a small number. And as also shown on this slide, what reduces oxygen content clinically most often is a decrease in hemoglobin. So if the hemoglobin goes down, that is the most important determinant of changes in oxygen content. Now, I should add, that does not mean that we should transfuse all our patients up to a hemoglobin of 15 or higher, because there are randomized controlled trials that show that lower targets for hemoglobin in critically ill patients, targets of 7 to 8 for hemoglobin, might be associated with better survival than more aggressive approaches to transfusion. So transfusion is not without risk, I guess.
Can I ask you a quick question?
Yeah.
Rather than wait.
Doesn't even have to be a quick question.
Because I'm going to forget this by the end.
Yeah.
So with that in mind, that particularly in the surgical units, they're very tolerant of low hemoglobin.
Correct.
So
I think in medical units too.
Yeah.
Because anymore, yes.
So does that mean we should be in the state of a low hemoglobin? Should we be here on the side of more oxygen?
Okay, hold that thought because I got slides on that.
I'm not a plant. I really do.
I got a whole slide on that. The short answer is no,
okay.
But I'll show you why in a minute. So this then brings us to physiologic causes of hypoxia. I think in the last talk we discussed physiologic causes of hypoxemia, a low oxygen in the blood. Physiologic causes of hypoxia here, low oxygen in the tissue. So there are 5 causes. Actually, a lot of textbooks only list 4, but there are actually 5. My textbook lists 5. They are hypoxemic hypoxia, so that's low inspired oxygen or lung disease, anemic hypoxia, which is sort of what we were just talking about, which is anemia, carboxyhemoglobin, methemoglobin, circulatory hypoxia, poor cardiac output, and peripheral shunts. And more about that in a minute. And then the one that is not in a lot of textbooks is affinity hypoxia, which is the result of a left shift of the oxyhemoglobin dissociation curve. So earlier I said that if the O2 dissociation curve shifts to the left, the hemoglobin holds onto its oxygen more tightly. The implication of that is that it doesn't release its oxygen to the tissues and can cause hypoxia. So severe alkalosis, for example, can cause tissue hypoxia because hemoglobin does not release oxygen as well to the tissues. And then there's histotoxic hypoxia, where there is a problem within the cell, typically within the mitochondria of the cell, and that can be the result of things such as cyanide poisoning or sepsis. As I will mention in a few minutes, with sepsis, there is histotoxic hypoxia, so the cells don't use oxygen. That results in hypoxia. And carboxyhemoglobin causes issues with utilization of oxygen in the cell, as well as with oxygen transport. So then how do we recognize hypoxia when we see it? Well, clinical signs aren't very good, as you, I'm sure, all appreciate. So with hypoxia, there are neurologic signs such as confusion and coma, but there are lots of things besides hypoxia that can cause confusion and coma. Tachypnea, tachycardia, lots of things cause tachypnea, tachycardia. Cyanosis is not very useful. Patients can be profoundly hypoxemic and hypoxic without cyanosis. And then increasingly, the 2 measures that I believe are being used to assess hypoxia are lactate and central venous or mixed venous blood gases. So normal lactate is less than 2 millimoles per liter. in patients with tissue hypoxia, the lactate is elevated. And I believe now that lactates are probably used pretty routinely in patients with sepsis, for example, to monitor the degree of hypoxia. And then the central or mixed venous blood gas. So ideally this would be a mixed venous blood gas, but hardly ever a pulmonary artery catheter is used anymore, so it's often a central venous blood gas, which is in most patients nearly as good, not perfect. Notice this is central and not peripheral venous, so we could get into a discussion of issues with central versus peripheral venous blood gases. Normal mixed venous PO2 is about 40 millimeters of mercury, and normal mixed venous oxygen saturation is about 75%. If the mixed venous oxygenation is either decreased or increased, that can be a sign of hypoxia. So, for example, if the mixed venous PO2 is 30 and the mixed venous oxygen saturation is 60%, that suggests hypoxia because that suggests the tissue PO2 is only about 30 millimeters of mercury. On the other hand, I think I did point out on a previous slide that with sepsis there's histotoxic hypoxia. So that with sepsis, the cells, the mitochondria, do not use oxygen normally. So you might hear some people refer to that as mitochondrial injury as a result of sepsis. Because with sepsis, the cells cannot use oxygen because of that cellular injury. It's not unusual that with sepsis, the PO2 could be elevated, 60, 70 millimeters of mercury, and the saturation might be elevated corresponding to that because the cells are not using the oxygen. The cells cannot extract the oxygen, so then the oxygen is not extracted from the arterial blood and the mixed venous is elevated. So looking at central venous or mixed venous oxygenation as a reflection of hypoxia is tricky because with sepsis specifically, it can be either increased or decreased with hypoxia. So there, the lactate may be more useful. So with sepsis, mixed venous oxygen saturation might be 80%, but the lactate might be 5. Okay, so because Kevin asked that I put in this slide, I'm happy to oblige. So imagine that our patient has a hemoglobin of 12 and a PO2 of 80 and an oxygen saturation of 95%. So that's typical of what we might see in our patient. So that results in an oxygen content of 15.5 milliliters of oxygen per 100 milliliters of blood. If the cardiac output is 5 liters per minute, then if I've done the math correctly, the oxygen delivery to the tissues is 775 milliliters of oxygen per minute. So that's just straight up math, which I think is correct. I've checked it a few times. And I've used this slide in other settings, and nobody's ever come up afterwards and said your math's wrong. Probably because they didn't want to bother doing the math themselves. So now let's imagine that the cardiac output drops from 5 liters per minute to 3 liters per minute. Well, that's something that might happen clinically, not too far-fetched. So now the oxygen delivery drops to 465 milliliters of oxygen per minute. And that could result in tissue hypoxia due to decreased oxygen delivery to tissues. So then the question might be, well, could we just turn up the oxygen on the ventilator to bring this back up to 775? Right? A reasonable question. Well, let's do that. Let's turn up the FiO2 and bring the PO2 to 150 and the saturation to 100%. What does that do to oxygen delivery? Almost nothing. The oxygen delivery goes from 465 to 495. Very little effect. So this then would suspect that suggests there's little benefit from increasing the PO2. Was this sort of what you were getting at, Kevin?
Well, I was just looking at it, just isolating the hemoglobin piece.
Yeah.
Because
So,
it seemed like
so we could do that.
the hemoglobin drop is the thing that seemed to affect content the most.
Correct.
Of the things
So
you
we could
listed.
do the same math, and we could manipulate the hemoglobin rather than the cardiac output, and we would come up with similar kinds of results, where increasing the PO2 has little benefit, because if your saturation, you can't get the saturation over 100%. So if the saturation is 97% to begin with, getting the saturation up to 100% is only a small increase in saturation. And the PO2 is not very important. It's only 0.003 milliliters per millimeter of mercury, the solubility coefficient. So there's little benefit for increasing the oxygen. So then, what should be the oxygen target, and is there harm if we do this? And increasingly, there is evidence that this is very little benefit. And you actually gave me an idea, Kevin. The next time I do this, I'll put on the slide the math for changes in hemoglobin as well. So we keep the cardiac output at 5, and we'll drop the hemoglobin from 12 to 8. And it would be a very similar kind of result. So a reasonable oxygen target, I would suggest to you, would be a PO2 between 88, 90, or an oxygen saturation between 88 and 95%, and a PO2 between 55 and 80 millimeters of mercury. That's what was used in the original ARSNet study that was now done back in the 1990s. And it turns out, although these ranges were a little bit made up by the ARSNet investigators, it turns out they are pretty reasonable. Because lower PO2s and lower oxygen saturations relate in hypoxia. So we want to stay out of this yellow zone here. But as it turns out, the higher PO2s and higher oxygen saturations also may result in harm. So we may want to stay out of the purple zone as well. So there are a number of potential harms related to an increase in FiO2 and PO2 and oxygen saturation, some of which are listed on this slide. And I'm not going to go through and talk about these in detail. In the adult ICUs, we don't think so much about retinopathy of prematurity, but certainly in neonates. But I put in this slide to serve as potential mechanisms, which is what I'm going to show on the next slide, which there are now retrospective studies and randomized controlled trials showing that higher PO2s, higher FiO2s, higher oxygen saturations might contribute to mortality. For example, this is a study just published a few months ago from the ARSNet group, where they went back and they looked at all of the patients who were in the ARSNet studies over the last 15 years. And they looked at the effect of high FiO2s, or oxygen exposure, on the odds of death. And without getting into the details of the methodology that they used in the study, let me just point out that the difference between the blue and the red and the black bars and dots are increasing levels of oxygen exposure. In other words, allowing the oxygen saturation to be greater than 95% as a result of an increase in FiO2. So that's the patient in the unit who's on 60% oxygen, has a saturation of 99%. So what they found was that for either mild, moderate, or severe ARDS, the greater the oxygen exposure, the greater the odds of death. So mortality was increased with exposure to excessive oxygen. In other words, allowing the oxygen saturation to be greater than 95% because of a higher FiO2 setting on the ventilator. And it looks like there is a dose-response relationship. The higher the oxygen exposure, the higher the mortality. So that would suggest that maybe it's not such a good idea to let the oxygen saturation hang on 98%, on 50 or 60 or 70% oxygen. Now, this is a retrospective study, which there are potential biases in that. But there are now also randomized controlled trials. So in this study, published about 2 years ago, patients in the ICU, not all on ventilators, but many of them on ventilators, were randomized into 2 groups. In a conservative oxygen group, the patients were targeted for a PO2 of 70 to 100 millimeters of mercury, and oxygen saturation of 94 to 98%. So that might even be higher targets than what I had pointed out previously from what was used in the ARSNET study. And then in the conventional oxygen group, the PO2 was allowed to be as high as 150 millimeters of mercury, and oxygen saturations were allowed to range between 97 and 100%. So let's look at ICU mortality. In the more conservative oxygen group, the mortality was 12%. In the patients who received more liberal oxygen, the mortality was 20%. So the mortality was almost twice in the patients who received more liberal oxygen administration. So then, hypoxia is bad. No argument about that. But hyperoxia, unnecessary exposure to high FiO2s, might be harmful as well. Look at another randomized controlled trial.
And these are batch just normal patients, not patients with ARDS.
Some of them, so this is in a mix of patients in the ICU.
So
Some with ventilators, some not on ventilators, some with ARDS, some not with ARDS. So this is kind of the basket of patients that you would see in a typical ICU.
So they're all critically ill?
They're all critically ill, so they're all in an ICU. So then, what about patients who are not critically ill? Or patients who, they may be critically ill, but they have COPD, and the ambulance picks them up. So what's the first thing that the attendants, the paramedics, and the medics do?
Not a breather.
They give them a lot of oxygen. So that's been studied now too. So this was studied 8 years ago. The study was probably done 10 years ago. So in this study, which was in a pre-hospital setting, in patients with COPD, the patients were randomized to whatever oxygen they get. It's usually face mask oxygen, 5 to 10 liters per minute. Or oxygen titrated to pulse oximetry with a saturation of 88 to 92%. So again, in parentheses, we're looking at mortality. Uncontrolled oxygen, 9% mortality. With titrated oxygen, 4% mortality. Mortality was twice as great in patients who received liberal amounts of oxygen. Number needed to treat for harm of only 14. So in other words, for every 14 patients who got excessive oxygen, 1 patient died. That, to me, is food for thought. We're at the meeting, we're likely to have a bad outcome. So. And that ARSNET data tends to show there's a dose-response relationship.
If you're covering this later, then forget about it. But
or if I don't want to.
Yes, then just choose to pass. Our culture for O2 titration for procedures is significant, especially in critical patients or patients that are peri-ICU. Transferring to OR, transferring back. Having a drug, having this, having that, having a ketamine dressing, needing 100% for no reason. So the idea that
bronchoscopy probably the most common.
We increase these regularly. Is that, and then might happen several times. Is that
so
because the break is there? It's not as important?
Yeah. So short answer would be not studied to the best of my knowledge. That would be a great study to do.
It's just blanket.
So right, I would think that my first blush response would be, well, for limited short-term exposures, maybe not so bad, but we don't know that, and there's probably an accumulated effect over time. So So take a patient who is getting a bronch, going to CT, that might be a significant amount of the day where they're exposed to a lot of oxygen. So the interesting study to do would be to, in patients with procedures and transport, what if they had titrated oxygen during the procedure versus if they always got put to 100%. That would be quite interesting, because maybe that patient on 40% and we put on 100% for a bronch, maybe they only need to go to 50 or 60%. That may be, I don't know, but that would be interesting to look
sure
at.
the awareness is there as much as the awareness of the overall.
Yeah.
Show up to Blake Ford for your colonoscopy, they're going to give you a cannula.
Correct.
I never needed a supplemental oxygen in my life.
Correct.
Go over there.
Right.
What's this for?
Right. So I
2 liters.
So I showed
2 liters.
yeah,
Everyone
so-
has 2 liters, Kevin.
So I showed up for my colonoscopy with my CPAP machine as I was instructed to do, and so then the other thing then they had a hard time figuring out how they're going to add the oxygen, how they're going to add the capnography, because they say they have to do that. This is at North Shore, it wasn't here, and they may do the same thing here. So then the GI doc comes in, and the nurse is saying, I don't know how to hook up the capnograph. And he said, don't worry about it, doesn't make any difference anyway. And I thought, do all this kind of stuff and nobody pays any attention to it.
How about, I was in the cardiac CT the other day, just with my students and trying to follow with the hyperoxia, reason of studies and everything. And I was told by the nurse, I don't know what the deal is with this weaning the oxygen too fast. These patients have healthy lungs. They just have the cardiac surgery. I mean, I say we never go below 40%. I don't care what the PO2 is.
No,
and anybody that wants to drop below 40%, I want a gas that shows me what the PO2 is.
Oh my.
And I said, well, and she goes, I think the heart needs all the oxygen it can get. And I said, well, we're just going.
Well, we just
multiple studies
we
here
just had a whole
that
lecture on
shows
that, right?
yes, what happens in the heart. And there was an intern or resident sitting beside her going, it was like, I was kind of going,
But we just showed that getting the oxygen up to 100% doesn't make that much difference.
No, not only that, it doesn't.
Yeah, it may do harm.
Myocardial.
Yeah, it may do. It may do harm.
Yeah,
I think the OR take them out, not always on 100% now. Out of
They
the
bring
OR.
them back.
Not in the
They bring them.
cardiac.
They bring them back on like 65%,
Provided there's
60%,
oxygen.
and the nurses are like, "Why are they on 60%?"
Oh, yeah.
And I was like,
Oh,
"Why
because they
not?"
want higher?
Yeah, we
The
know.
nurses like,
Yeah.
they're just like, they're like, "Oh, we want 100% gas." I'm like, "What does that do for you?"
So I'll tell you an anecdote. So from a few years ago, it was thought that it would be a good idea that I take assignments sometimes. It was probably okay. I don't think I hurt anybody. So I'm assigned as a second in the neuro unit, and so I have my 3 patients on ventilators, and one of them I go in and they've just gotten a blood gas back, and the patient's on 40%, that's 100, and PO2 is like 180. So I weaned the patient down to room air.
Boy.
And the nurse said, nobody ever did that before. And I thought, probably she wasn't going to pick a fight with me, but for any one of you, would have probably raised hell until you put it back to 40%, just because, I never saw that before.
Still do, Dean.
Yeah. I mean, it's a change of practice, but it doesn't seem like it's getting through
Yeah.
to everybody.
Well, it's
Old
getting through
habits, bad
slowly.
habits.
Slowly.
I run a
Old
report
habits.
that gathers, will tell me of all our ventilators, how many were at FiO2. How many are on 21%? We had 50%, 50 ventilators running, and like 19 of them were on room air.
Really?
Pretty incredible, yeah.
That is.
Now that might have been an anomaly, but 10 years ago you ran that, you probably would have got 0%.
Zero, yeah.
Yeah, I think there are probably a lot of people who thinks that the ventilator FiO2 control stops at 40.
Yeah.
You know,
Oh, yeah. And it's a culture thing, and
It is, yeah.
we have to own a piece of that. I still, when I approach this, I said, leave them at 97%, what's the big deal?
I think some of the more
If
exposed.
nothing else, you won't be calling me when it dips from
No, I
96
mean,
to
we used
93.
to, myself included, we always felt good when we came on at the beginning of the shift and the sat was 94% and we went home at the end of the shift and it was 100%.
Yeah,
Oh, that feels good, right? But it might not be the right thing to do.
And it slowly transitioned in the delivery room, you know.
Yeah.
Now, you know,
So you're
actually
right.
resuscitating a baby in room A. Just it was pretty
Right, because
Yeah,
there's a
yeah,
big
yeah,
deal with
yeah.
retinopathy,
Yeah,
prematurity, and PPD,
Yeah,
and
yeah.
so.
And that's taken a long time, because that data,
That took a while, yeah.
that's been around from day one.
So you know, and I should have put the slide in here, about a year ago, there was a paper published in the New England Journal of Medicine where patients in the field were randomized to either get high levels of oxygen if they had suspected MI, which is standard practice, or to keep them on room air unless they had low oxygen saturations. And the ones who got 100% oxygen had no better outcomes. They were exactly the same as those who got room air. So yeah, but it's a different way. It's a different way of thinking. I was watching something, I guess to get to Liz's point, I was watching, kind of half watching one of the Netflix serials that my wife watches all the time, and so there was a patient who was getting a procedure in an ICU, and somebody said, "Is the oxygen on 100%?" You know, because that's just what we had all been ingrained to do.
But, and I do think
And maybe it doesn't matter for 30 minutes or 15 minutes, but the other
Right.
thing is, think about it. And you don't have to answer, but think about it. How often have you been told that they're going to do a bronch at whatever time? So you go in there 15 or 20 minutes before and turn up the oxygen to 100%, and then they show up late for the bronch, and then things get busy, you get called out of the room, and then all of a sudden the patient's on 100% oxygen for 4 hours. I mean, I'm sure that never happens, right? But it's just sad.
And it's a visual thing sometimes with the nurses, like, or with anybody, but like.
Yeah, I think we all share part of this.
Yeah.
It's like a security
Often-
blanket kind of thing.
Right, we'll go to a rapid response, and how many times have you seen a 5-liter non-rebreather, you know, on a patient who's in distress? And so the initial thing is give them more, but it's more set the device appropriately,
Yeah,
not give them all the
Correct.
oxygen possible. But
Right.
in other people's mind is like they weren't getting enough. So.
Right. So the point of that slide with 88 to 95 and 55 to 80 is that we have to be in the appropriate range. Nobody would argue that too little is bad, but I think we're having accumulated evidence that too much may be bad as well. Yeah, I remember years ago, I used to always tell my students, you know, don't be afraid of administering oxygen. Lots more patients die of hypoxia than die of hyperoxia. Well, you know, the data has proven that statement wrong, right? Okay, let's talk a little bit about CO2 transport. Now we'll wrap it up. We'll save the acid base for another time. Because there's another important point that I want to get here to in a minute, which actually relates to oxygen administration as well. So carbon dioxide is transported in the blood in 3 ways. As carbamino, CO2, that is carbon dioxide bound to hemoglobin. So hemoglobin is also important for CO2 delivery. As bicarbonate, and the lion's share of CO2 in the bloodstream is as bicarbonate. So in other words, when the lab reports a venous total carbon dioxide, essentially that's bicarbonate, because most of that's bicarbonate. Only a small amount are dissolved CO2 and bound to hemoglobin. And that is illustrated on this slide. So here is the red blood cell, hemoglobin inside the red blood cell, normally not outside the red blood cell. So CO2 comes out of the tissue into the bloodstream. A small amount of carbon dioxide is dissolved in the blood. Like oxygen, the solubility of carbon dioxide in the blood is not very great. much of the CO2 diffuses into the hemoglobin, and inside the hemoglobin there are two important things that happen. Some of the CO2 binds onto hemoglobin, and that's called carbaminohemoglobin. That transports oxygen. And then within the red blood cell is an enzyme called carbonic anhydrase. And carbonic anhydrase allows the production of carbonic acid and then bicarbonate from the CO2. So much of the CO2 that dissolves into the bloodstream goes into the hemoglobin. In the presence of carbonic anhydrase is converted to bicarbonate. The bicarbonate diffuses back out into the serum, and at the same time, to maintain electrical neutrality, chloride shifts to the interior of the cell. And you may have remembered years and years and years ago in a physiology class they called this the chloride shift. The shift of chloride into the red blood cell as bicarbonate comes out. Now we talked about the Bohr effect and how the Bohr effect is the relationship between pH and the position of the oxyhemoglobin dissociation curve. If we look at the CO2 dissociation curve, we can talk about the Haldane effect. So, first of all, if we look at the CO2 dissociation curve, you notice that it is much more linear. It is essentially linear, as opposed to the S-shaped oxyhemoglobin dissociation curve. So you appreciate the linearity of the relationship between CO2 concentration and PCO2. But you also notice that the relationship is affected by the oxygen saturation. So an increase in oxygen saturation causes the curve to shift to the right. So, for example, if the PCO2 is 60, so imagine your patient with COPD with PCO2 of 60, that relates to a total CO2 concentration of 60. And the units are what? Milliliters per 100 milliliters of blood. Now let's imagine that we put that patient on a non-rebreather. And we raise their oxygen saturation from 75% to 95%. That causes a right shift of the CO2 dissociation curve, and now with the same total carbon dioxide concentration in the blood, the PCO2 goes up. And this is probably the best explanation for why hypercarbic patients with COPD have an increase in their PCO2 if they are administered oxygen. Because the oxygen and the carbon dioxide compete with one another to bind onto the hemoglobin. And the more oxygen that binds onto the hemoglobin, the more carbon dioxide is released from the hemoglobin. And that results in a higher PCO2 for the same total amount of carbon dioxide in the bloodstream. So the Haldane effect is probably the predominant reason why patients have an increase in PCO2 if they are administered supplemental oxygen. And it is not because we shut off the hypoxic drive. And when we talk about control of breathing, a couple of lectures along the way, well, and you know about P100s because you measure them off the ventilator, but patients, if you measure P100 in a patient with COPD exacerbation in the emergency department, it's really high. It's -10. And then if you give them oxygen, it might go from -10 to -8. It might go down, it might change a little bit, despite that their PCO2 might go up a lot because of the Haldane effect. So they have, patients with COPD, I used to say, but the commercial hasn't been on television for a while now, I used to say that COPD patients are Toyotas. They're driven to breathe. If you remember the old Toyota commercial, we are driven, so it's bad, I know, but particularly because they haven't used that commercial in 10 years now. Okay, so with that, I think we will stop because we're not going to have time to get through all of the acid-base balance stuff, so we can save that for another time. So I think covering oxygen transport and CO2 transport with some clinically relevant discussion around the meaning of that physiology is enough for one day.
Thanks, Neil.
Thank you very much.